Hello and welcome to Pace Hospital's podcast. Today, we are exploring a condition that is often misunderstood and affects thousands of people worldwide, that is interstitial lung disease or ILD. Joining us today, Dr. Pradeep Kiran, consultant interventional pulmonologist and specialist in bronchoscopy and EBUS. In today's episode, he would like to explore what is interstitial lung disease, what exactly causes interstitial lung disease, and how it is treated. Dr. Pradeep, thank you for joining us at Pace Hospital's Hitech City. Let's understand exactly what is interstitial lung disease.
Hello everyone, I am Dr. Pradeep Kiran Panchadi, consultant interventional pulmonologist in Pace Hospitals, Hitech City and Madhapur. Now today we will be discussing about some of the most important topic which is mostly misdiagnosed because of its similar presentations to asthma and COPD. So the topic that we are going to describe today is interstitial lung diseases, otherwise these are called ILDs. So how come this is being misled? Because most of the cases where ILDs are present, patients will be having similar symptoms as asthma like breathlessness, chest tightness, not able to walk for long distances and wheezing. All these are most commonly diagnosed as asthma without proper diagnosis. So let's come to what is this ILD or interstitial lung diseases mean. It is an umbrella term used for diffuse pulmonary fibrosis or the scarring of the lungs. This scarring leads to impaired mechanism of oxygen and carbon dioxide diffusion and exchange, so leading to breathlessness. How does this work? Because our lungs are sponges. As you all know, lungs are very sponge-like. They will be having air entry into that air and exchange of gases between the lungs and blood. So now, when the sponge gets deformed or deranged, this mechanism of gaseous exchange between blood and air is compromised. That's what leads to the breathlessness. So in ILDs, because of this scarring, you will be having mismanagement or mismatch of diffusion of gases. So I already told you the definition of ILD. So a little bit about the history of ILDs, because it's a long-term disease where initially it was thought, as I told you earlier, that most of the cases it is misdiagnosed. In the similar way, in previous era, during 1890s, the first one scientist, he coined the term chronic interstitial pneumonia. So because they thought that whatever pneumonia at that time that was not resolving, they put it into a collective term telling that chronic interstitial pneumonia. Later on, various scientists came and very advances came. In between, two scientists named Hamann and Rich, they presented this scenario and named this as Hamann-Rich syndrome. So again, because Hamann-Rich syndrome, they coined the term, but they saw variations in presentations. So again, they differentiated this Hamann-Rich syndrome into acute Hamann-Rich syndrome and chronic Hamann-Rich syndrome. As the days progressed and medical field has improved in its technology, then the other terms, most importantly cirrhosis. As we know that cirrhosis is usually used in liver, it is the term also used for lung, that is called cirrhosis of the lung. One term was coined. But as and when progressed, it came to be known that this disease is not a single disease. It is an entity, it's a group of diseases ultimately leading to the scarring of the lung. So ultimately the term interstitial lung disease have been coined, because the reason for coining this term is it is mostly involves the interstitium of the lung. Interstitium means the tissue that is present between the air and the blood vessels, the soft tissue. This will be hardened. So that's why the term interstitial lung diseases have come. Now, in the recent century, again the terminology have been revised, and now it is being called as interstitial idiopathic pulmonary fibrosis, IIPF.
What exactly causes interstitial lung disease?
So how does this come? What are the reasons? So there are a multiple of reasons, as and when, as I told you, that as the medical knowledge is improving, the investigations are improving, we came to know that there are about 160 causes of this disease, ILDs. So there's an American Thoracic Society, Japanese Respiratory Society, European Respiratory Society. All these bodies, they came together and they formulated a guidelines for the diagnosis and classification of this ILD. So as per the classification, it included which have causes, which do not have causes. The diseases consisting of ILDs which doesn't have any cause are called idiopathic diseases. The most important of them is idiopathic pulmonary fibrosis. This is the most severe form of ILD. And the other include interstitial disease, lymphoproliferative interstitial pneumonia. Other forms are there. And what are the causes? The most important causes that the scientists or medical professionals have come for ILDs are autoimmune diseases, out of which connective tissue disorders form the bulk of the causes. So rheumatoid, may it be rheumatoid arthritis, might be sarcoidosis, which is one of the most important causes, or any other causes which lead to this which are leading to fibrosis or scarring can lead to interstitial lung disease. And the other thing, allergies or occupational exposures. The common terminology for ILDs causing in the work environment is called occupational lung diseases. This occupation can be farmer, where it is called farmer's lung, the most common cause being the hypersensitivity pneumonitis. And in the same way, coal workers pneumonia, in the same where there will be pneumoconiosis, that is leading to ILDs. Silicosis, asbestosis, all these things where the workers or persons are exposed to work exposure, leading to this exposure will ultimately lead to hypersensitivity reaction in the body and in the lung, leading to hypersensitive pneumonias, ultimately landing in interstitial lung disease. Or the final terminology is IPF, idiopathic pulmonary fibrosis.
How do we classify interstitial lung disease?
What happens to histopathologic difference means what happens in the lung, microscopic structure of the lung. Based on that, scientists again have divided into multiple terminology. UIP, usual interstitial pneumonia. This is a term, histological term used when there is honeycombing or diffuse scarring of the lungs, mostly involving subpleural regions, the basal regions. There is another term called NSIP, non-specific interstitial pneumonia, where the scarring is very less, but it will be more looking like a ground glass opacities. Other terms are COOP or BOOP, bronchiolitis obliterans organizing pneumonia, where the most common finding will be diffuse patchy opacities involving in both the lungs, leading to desaturation. So all these are coming to classifications.
So doctor, how is ILD diagnosed? What are the various diagnostic methods?
So how do you diagnose this case? Because I told you in the first itself that is the most commonly misdiagnosed disease or diseases. The reason being, the symptoms, the usual clinical symptoms are the same for everyone. There will be breathlessness, there will be dry cough. There sometimes when there is any secondary infection, you will get fevers, and patient will be having symptoms of when the disease is very severe. These symptoms relating to other systems may also be like the most common being heart. This ILDs ultimately they will be leading to heart failures also, right side heart failure, leading to swelling of both the legs, swelling of face, hypertension, all these things will be there. So the symptoms are all the same. How will you diagnose? Suspicion or doubt whenever a patient enters into our chamber, the most important thing is it starts from history. When a patient tells history regarding occupational exposure or any rheumatoid arthritis or autoimmune disease like symptoms or unnecessary sudden onset of dyspnea or SOB, breathlessness, all these conditions, they will be pointing this towards the suspicion. And this should be followed by our examination. Usually the medical examination, physical examination will be leading to, generally it will be having clubbing, that is the swelling of the nail bed, that may be there. This is a important finding in lung diseases. Followed by other important thing is clinical examination auscultation will be finding a characteristic coarse to fine crepitations. These are called Velcro crepitations. So that means the crepitations also, they will be varying with position. When the patient bends forward, the crepitations will be decreasing in intensity. So, and other investigations including saturation, SpO2, it may be low or may be normal. It depends on the severity of lung involvement. Every ILD patient or every IPF patient may not necessarily have a low saturation. It depends on the extent of lung involvement. So coming to the diagnosis, as I told you earlier, that it is the history, physical examination followed by our lab investigations. The most important and the gold standard investigation at the present time for diagnosing ILD is HRCT, high resolution chest tomography. This will be conclusive in about 95% of the cases. So in earlier days, it is the biopsy, the surgical lung biopsy was the diagnostic measure, golden investigation of choice, but now it's an invasive procedure. Now HRCT is more than sufficient. In whoever patient who are having doubt, they can be complemented by other blood investigations like ANA profile to rule out any autoimmune disorders, or ANCA, or other investigations like CBP, knowing the extent of the disease. Bronchoscopy, which is the most common used investigation in pulmonary medicine, can be used in other ways also. The bronchial lavage fluid that has been taken from the lungs of the patient can be sent for various investigations like CD4 by CD8 ratio in case of sarcoidosis, eosinophil count in case of hypersensitivity pneumonitis, or a simple cell count may give the prognosis of a patient, ILD patient. Neutrophilic ILDs have a better prognosis when compared to a lymphocytic proliferative diseases. In the similar way, the biopsy, nowadays biopsy is being done by cryo lung biopsy. This is a bronchoscopic guided biopsy where a cryo probe will be there which can be passed into the so-called areas, and the biopsy piece can be taken and the histologic diagnosis can be made. So these are all the diagnostic procedures. Again I am saying HRCT is the first and foremost, followed by, if at all biopsy is needed, it is a cryo lung biopsy that is preferred nowadays. Transbronchial lung biopsy, nowadays it's not being so encouraged because of higher chances of developing pneumothorax in these cases. So next, what can we do? Sputum investigations. Sputum investigations carry importance only in case of secondary infections because ILD patients, they are immunocompromised when compared to when concerning the lungs. So these cases, patients, they will be developing TB and other opportunistic infections. So in those cases, you can have sputum investigations. Otherwise, sputum investigations have no major role in ILDs.
How is interstitial lung disease treated?
Coming to the treatment, as I told you earlier, it is a fibrosis, scarring. Lung is an organ in our body where there is no repair. Means we cannot regenerate. What is lost is lost. There is no repair. So we have to give the most common treatment is symptomatic treatment. The treatment will be involving as it is given in the asthma. The same thing is inhalers will be given to control the breathlessness and also other drugs to support this symptomatic treatment. And coming to specific treatment is usually there is no specific treatment. If it is an autoimmune disease, then we can give as per the autoimmunomodulators like azathioprine, cyclophosphamide, MMF, mycophenolate mofetilate. All these things, they can be given as a adjuvant therapy, but these cannot be given 100%. The newer armament that we are having are anti-fibrinolytic therapy. That means these drugs will impede or slow the rate of scarring of the lung. The most common being pirfenidone, nintedanib. These two drugs, because of the COVID pandemic, they have become so famous. But these have been using in the ILD cases or IPF cases for a long time. And these drugs will only slow the process, but they will not halt or stop the undergoing process. And others like antioxidants, N-acetylcysteine, and also nebulizations, they can be given as and when necessary. So what are the ultimate treatment if both the lungs are damaged or one lung is extremely damaged, it is out of repair and patient is symptomatic worsening, and if his heart is not involved, like carpulmonale, where the pulmonary arterial hypertension will be increased, in these cases they can be taken for lung transplantation. Obviously, lung transplantation is a procedure which involves a lot of financial backup and also expertise, and the patients have to, that's why lung transplantation is more preferred in younger patients when compared to older patients.
So, doctor, what are the complications of interstitial lung disease?
So what are the complications related to this ILDs? So most common complication is respiratory failure. Because of inability to exchange oxygen and carbon dioxide, patients will initially they will be having low oxygen, that is hypoxia, and as the disease progresses that will be converted into hypercapnia. Carbon dioxide will also be retained in the lungs, leading to type 2 respiratory failure. These patients may be requiring oxygen support at the home, long-term oxygen therapy, and also CPAP or BiPAP support to maintain their lung function. Other complications, as I told you in the initial stages, symptoms, heart will be involved, where if heart is involved, right heart failure might be there, leading to heart failures and all the symptoms of heart failure. Some patients, these patients are more prone for clotting of the blood in our vessels, like elevated because of increased viscosity in the blood. This may lead to heart attacks, brain strokes, or lower limb deep venous thrombosis. All these things will be there. So ultimately, a person with ILD, if he is diagnosed early, his outcome or life expectancy can be increased. Unnecessary delaying by not misdiagnosing these things may lead to terminal stages where the life expectancy of the patient may not be more than 5 years. In sometimes it is less than 3 months. So please open your eyes. All that wheezes, every breathlessness is not asthma. It can be other things like ILDs. I hope you understood the importance of this disease.
Thank you, Dr. Pradeep, for being with us, for sharing crucial information on the topic of interstitial lung disease. If any of you have any further questions regarding interstitial lung disease, please don't hesitate to consult a pulmonologist. Remember, awareness and education are key in the fight against ILD. We will be back soon with another episode on Pace Hospital's podcast. Until then, stay informed, stay empowered, and take care of yourself.